Greetings from the National Institute of Mental Health and Neurosciences, NIMHANS, Bengaluru, India. Some of the faculty from the departments of Psychiatry, Clinical Psychology, and Psychiatric Social Work of the Psychiatric Rehabilitation Services of our institute are going to present a symposium on psychosocial rehabilitation for persons with schizophrenia, a real-world perspective from India. We declare no conflict of interest. The learning objectives of this symposium would be that at the end of this symposium, the audience should be able to identify, discuss and explain practical challenges in providing psychosocial interventions for schizophrenia in low-middle income countries, and experience of providing the following, that is cognitive remediation, community-based rehabilitation, and supported education and supported employment. The American Psychiatric Association has in the guidelines recommend and suggest a few evidence-based psychosocial interventions in schizophrenia. These include CBT for psychosis, psychoeducation, supported employment services, assertive community treatment, family interventions, and so on. Now, the evidence-based psychosocial interventions pose several translational challenges. These include human resource challenges, training of therapists, multiple therapeutic challenges, durability of effects, etc. I'm going to talk about each one of these in a little more detail in my following slides. Now, India has about 5 million persons with schizophrenia. Majority of them need psychosocial intervention, and they need it for several years. But our mental health professionals are very few, as you can see in these figures. And most of the mental health professionals are involved actually in acute care psychiatry, and they are concentrated mostly in major cities. Now, the evidence is there for therapies delivered by highly trained therapists who take part in rigorously conducted RCTs. But in reality, very few mental health professionals have formal training in all these interventions. And even in affluent countries, such therapies are seldom available beyond academic settings. And we don't have evidence for these interventions delivered by less trained, less qualified professionals. Individuals with schizophrenia seldom present with single challenges. Multiple challenges are a rule rather than exception. Any combination of the following are frequently seen, that is social skill deficit, cognitive deficits, depression, residual psychotic symptoms, poor adherence to treatment, negative expressed emotions, etc., etc. Now, little is known about the interventions addressing a combination of these challenges. Most of the RCTs are targeting one of these symptoms. And we also don't know much about order in which multiple therapeutic challenges should be addressed, whether depression should be addressed first before cognitive retraining or vice versa. Who would provide therapy for these combination of challenges? Can a single therapist provide these evidence-based intervention for all challenges? Is it practical for patients to receive single type of therapies from each challenge from a different therapist? Is it possible? Is it feasible? Schizophrenia is a lifelong illness, but the durability of effects of therapies is not studied, not well studied beyond 1 to 2 years. Schizophrenia is also a highly relapsing disorder, and the durability of effects of multiple relapses is also not well studied. Type of psychosocial intervention depends on the life course of the patients. Patients go through different stages in life, including adolescence, young adulthood, middle age, older age, and their therapy needs will be according to their life stages. Supported education, supported employment, cognitive skills, social skills training, cognitive remediation, etc. may be required at different stages of their life. Now, it is challenging to find therapists to provide these varying types of therapies at different stages of their lives. There are cultural and social issues also determine the feasibility and acceptability of interventions of particularly psychosocial interventions. We know that even in the UK or US guidelines caution against extrapolating evidence of RCTs from each other countries. Now, very few psychosocial interventions are developed in low-income countries, and the relevance of psychosocial interventions developed elsewhere in these countries remains doubtful. Families are involved throughout the care of persons with schizophrenia in India, including identification of illness, seeking treatment, maintaining adherence, rehabilitation, etc. And models of interventions which do not include families may not be useful in countries like India, and such models are sparsely studied. Psychosocial interventions are time and human resource intensive, and little is known about their cost effectiveness in diverse settings. In India, health expenses are mostly through out-of-pocket or state-sponsored expenses. Now, affordability of either of these for different psychosocial interventions is questionable. For many clinical challenges in rehabilitation, evidence-based interventions are lacking. Some of these clinical challenges are extremely common, but we don't have evidence-based intervention. For example, do standard psychotherapies for depression work in schizophrenia? The social anxiety that we see in schizophrenia is not the same as social anxiety of social phobia. Do we have evidence-based therapies for this social anxiety which we see with schizophrenia? Very few interventions are developed for the following challenges, that is impulsivity, lack of foresight, stigma, study skills for students with schizophrenia. So we don't have evidence-based therapies for this, but these are very common clinical challenges. Now, what are the possible solutions? I will refer to this WHO pyramid framework. In the vast majority of patients at the bottom of the pyramid and their families may be self-reliant, and in any of them, pharmacotherapy alone may be sufficient or maybe good enough. But what is most important is we need to develop models of interventions provided by less qualified professionals for the middle range of patients. And we should expect that only a few may be offered services of specialized mental health professionals, that is at the tip of this pyramid. There is also need for us to develop indigenously some psychosocial treatments. Yoga therapy is well studied in NIMHANS. Home-based rehabilitation, particularly family-assisted cognitive enhancement, has been initiated and tested. Some indigenously developed sustainable models of community-based rehabilitation are also being examined in our institute. Now, I will hand over the podium to Dr. Devvarta Kumar from Department of Clinical Psychology.
The previous speaker talked in detail about the kind of challenges that we have in the lower and middle income countries as far as the psychosocial interventions and different psychosocial supports to be provided for patients with schizophrenia. I will primarily focus upon the cognitive remediation program, which is quite needed for people who are having schizophrenia. So the title of my presentation is Cognitive Remediation in Schizophrenia, a strongly felt need, challenges in provision of services, and the way forward. So these are some of the very quite established facts about cognitive deficits in schizophrenia. For example, we know that the cognitive deficits are manifested by patients who are having recent onset of the illness, as well as those who are having the chronic course. These deficits are quite widespread. It encompasses right from the basic cognitive functions such as attention to complex cognitive functions, for example, executive functions, and different aspects of executive functions. This is also established that this cognitive deficits are one of the important determinants of disability in schizophrenia. And these deficits influence the functionality of the individual in a major way. For example, is again meta-analytic studies show, quite a few studies have been done, which shows that apart from symptoms and other ability deficits, cognitive deficits become very important factor for determining the real world functioning of patients. And those who are having better cognitive functioning, they have they have better work outcomes. So the outcome in terms of the real world functioning is better when cognitive intervention is an integral part of comprehensive intervention program. So if right from the beginning, we include cognitive remediation program for the patients, then the likelihood of them recovering fast and becoming more functional is high as compared to those who are not provided or provided at a later stage. These are some of the examples that the kind of deficits, kind of impairments or the difficulties patients face because of the cognitive deficits that they have. And we can realize that because of these deficits, why their functionality, the prospects of getting employment and other things will be affected. For example, the attentional deficit is something that all of us observe very commonly in patients. And if they are having problem in attention and concentration, then they are not able to concentrate upon the task at hand. Likewise, due to working memory impairments, both verbal and visual, they have difficulty in any task which requires multiple steps, or if they have to juggle between more than one task, they find difficulties. Due to immediate memory, there can be problem in having meaningful communication with someone. Due to prospective memory impairments, they have problem in maintaining appointments. So, for example, many times patients do not come to at the time of the appointment. One reason can be they are not motivated to do so, but the other reason could be that they are having prospective memory difficulties or not able to take medications on time. Again, either it is a motivational factor or they keep forgetting about the intentions that they make. Likewise, due to executive function impairments, they can have problem in planning. They perseverate on the same task that they take. Due to social cognition deficits, they are having interpersonal problems. They are having difficulties in social reciprocities. So we can understand that these cognitive deficits are not just limited to their cognitive aspects. They have direct implications for their day-to-day functioning, as well as complex functions that they are supposed to execute in their life. There are quite a few approaches to cognitive remediation in schizophrenia. I'm not going to talk about this in detail because this is not the purpose of this presentation. Just to say that the cognitive remediation strategies are divided into different, these approaches are not as if something is restorative and compensatory, then they do not use the other approaches. It's a mix of things that are used. So primarily, either you have a focus on restoration of the abilities, or you try to compensate, which cannot be restored to the previous level. Then either we go for drill and practice or practice plus strategy approach. We have paper and pencil or computerized approach. We do home-based or clinical-based interventions, likewise we focus only on neurocognition, or we include neurocognition versus as well as social cognition. As I said, I'm not going to details, but these are some of the areas, these are some of the ways by which conduct the cognitive remediation program. Now coming to the Indian scenario, which more or less applies to all the lower and middle income countries, that we do not come across this component of intervention being used very frequently. Actually, they are very, seldom they are included as part of the comprehensive intervention program. As the previous speaker was telling that most of the time, if at all it is given, these are more or less to large hospitals with academic facilities and all. And on the other side, there is a strong felt need. For example, we conducted a countrywide survey, and we found that more than 75% of the clinicians felt, and this included clinical psychologists, psychiatrists, and psychiatric social workers. More than 75% clinicians felt that psychological interventions, including cognitive remediation, psychoeducation, social cognition, focused approaches, and CBT for psychosis should be an integral part of the comprehensive intervention program for schizophrenia. And interestingly, and I say unfortunately, that 1 in 3 clinicians reported that they did not have any formal training for these interventions. So one major reason for not provision, for lack of provision of these services is the fact that perhaps we do not focus these interventions while the training is given to the professionals. Now, the next problem is resource constraints. For example, for the patients, with the caregivers and the health professionals, we struggle to have the kind of resources that most of the psychological interventions require. For example, if someone has to come for cognitive remediation, and if you do it for 12 weeks, and if you call the patient at least thrice a week, which essentially means that 36 times they have to visit the hospital, which entails time, which entails money, and it becomes very difficult for them to afford that kind of thing. At the same time, as you heard, that the number of clinicians are so less that you cannot provide this kind of services to more than 1 or 2 or 3 patients in a week with 36 sessions or 24 sessions for one patient. So it is both ways. Neither the professionals are having so much of resources that they can provide this kind of services, nor the resource consumers will have the facility, or the service consumers will have that kind of resources that they can afford it. And as I said, that lack of training is one of the reasons, another reason that why these services are not being provided. And there are many other practical difficulties. For example, if the caregivers have to accompany, as you heard, that most of the time it is out of pocket expense by which you meet with the requirements of all the interventions. It becomes very difficult for the caregivers to afford this much of cost. The other thing is that they have to, for example, if a patient is visiting the hospital, the whole day the caregiver also is supposed to accompany him or her, which compromises their work and activities. So there are lots of practical difficulties for which it becomes very difficult for us to even if there is a felt need, we are not able to do much about that. Now, what is the way forward? We just cannot say that these are the limitations, these are the barriers, and we do not do anything. So the most important is that we utilize the resources that we have. The second thing is that we tailor the program in a way that it meets with the resource constraints. So one way is that we run these services as caregiver assisted home-based program. All of this may not be done, but then many of this can be done. For example, cognitive remediation, we have conducted at least 2 studies have been done at our institute. The previous research was quoted, and this research we have finished just 1 or 2 years back, where we found that caregiver assisted home-based cognitive remediations are possible, and they are as effective. In fact, we assessed different components, and we found that only in one component there was difference between clinic-based and home-based cognitive remediation. It was, I suppose, verbal working memory. Other than that, the intervention was as effective. Home-based cognitive remediation was as effective as clinic-based cognitive remediation. The other requirement, so we need to work upon developing this kind of caregiver-assisted cognitive remediation or other psychological interventions. We also need to use the assistive technologies. For example, right now, the mobile phones, the other gadgets, these things can be used for many of these programs, starting from psychoeducation and other basic things and going up to the higher, more complex kind of psychological interventions. The third thing which is required is that we need to involve frontline mental health workers in most of these intervention programs. And fourth thing is that we need to have low intensity interventions. So for example, when we are talking about involving frontline mental health workers, we need to have low intensity interventions of all these different kinds of requirements we have. And we also have to have extensive training of the professionals in these areas. So people should not come out with a degree, but they do not have exposure in these areas because they are not able to provide the services. So what are the efforts that we are doing in this direction? One, as I said, that we are trying to develop and empirically test the caregivers assisted home-based cognitive remediation modules. We are trying to test it more rigorously. So in next 2 to 3 years, perhaps we will test 1 or 2 models with more rigorous, empirical. This one, what kind of neurophysiological changes it makes, and if we find that it is having same kind of effect, perhaps we will have very effective cognitive remediation modules which can be easily delivered with the help of caregiver caregiver assistance. We also are working on developing low intensity interventions, so a smaller kind of important cognitive targets that we have. we need to sensitize the stakeholders, starting from the policymakers, the importance of all the remediations and services. And we need to have advocacy, and we are working on all those things. We try to sensitize as much as possible different stakeholders. So perhaps we have started working in this direction, but then a lot needs to be done. Thank you.
We will be sharing our experience of community-based rehabilitation for persons with mental illness in a rural area of South India. So we are implementing this program in a small taluk, that is a district sub-block by name Jagadisha in central Karnataka, which is a South Indian state. And it has a population of about 1.71 lakhs. And most of them live in rain-dependent rural areas. And mental health care was not available in this place before we started working there. People were not aware about mental illness, and those who were aware could not afford the treatment. So we started this community-based rehabilitation program on a public-private partnership between NIMHANS and Government of Karnataka, which are government institutions, along with non-governmental organizations, the Association of People with Disability, Chitta Sanjeevani Charitable Trust, and the Live Love Love Foundation. So the program was initiated in August 2015 by senior people from NIMHANS, as well as the elected representative of that particular sub-block. So we started by spreading mental health awareness, one by mental health wall writing in the walls of primary healthcare centers as well as the Taluk hospital, by conducting street exhibitions, by putting up stalls at the town marketplace, displaying posters, banners or flip charts and distributing handouts on mental health, by taking out on street rally to create more awareness. And we also did a skit competition on suicide prevention, where actually the local college students actually participated, and then we issued prizes for them. And we chose PHCs for conducting the mental health camps in which patients were actually seen. And this was in line with the Super Tuesday concept given by the government of Karnataka. And PHCs are known to public for health services. So it is ideal to integrate mental health services also there. In addition, we could also avail the presence of PHC medical officer, nursing staff and pharmacist. And in the long run, it also helps in sustainability and also builds to the credibility of the particular program. So there are about 10 primary healthcare centers, one taluk hospital and one sub-center in which we periodically go. And the places are repeated once in about 13 weeks. So for people who are unable to come to the primary health center, we also do home visits. So in this photo, you can actually see like where we have actually gone to the homes of people where the person was not in a position to come to treatment. And subsequently, once we initiate treatment, then the patients become better and they continue to follow up in the primary healthcare center. We maintain a database of persons with mental illness, and before 2 days of the camp, a telephonic follow-up is given. And if the person is absent for the camp, then we contact them by telephone. If they cannot be contacted over the telephone, then a home visit is done. Besides this, a home visit is done to all persons with mental illness once in 2 months if needed, and it is repeated at a greater frequency if it is needed beyond this. So over a period of time, we have built relationship with the key stakeholders, including the Taluk health officer, the PHC doctor, pharmacist, nursing staff, the group D worker, the ASHA facilitator, the ASHA worker. The ASHA worker is the lay health worker who works in maternal and then child health, reproductive and child health. And we also liaise with the Taluk administrative health officer as well as the district leprosy officer. So we had to navigate a range of challenges, including gaining the trust of PHC staff. There were challenges in intenting psychiatric medications through the primary healthcare center, and there were demands for remuneration of the work. And initially, persons with mental illness were not interested in attending the camp. But over a period of time, by liaison with the different stakeholders, with discussion with the district health officer, the district mental health officer, and the Taluk health officer, we have been able to ensure that psychotropic medications could be intended and made available in the primary healthcare centers. And over a period of time, the patients have also improved, and we have attributed the improvement to the cooperation extended by the lay health workers, and persons with mental illness have been motivated to come for regular treatment by repeated visits. So the strategy here is increase the awareness, ensure that people are initiated on treatment, ensure that they are taking the medications regularly on follow-up, psychoeducate, and over a period of time also form caregiver advocacy groups and engage them in vocational training or self-employment kind of opportunities. So in association with the non-governmental organization with whom we are working, We also conducted periodically 4 days residential camp where the audience is person with mental illness and the family caregivers. And there are resource persons, including the psychiatrist, the district disability welfare officer, and the NGO staff. So they offer psychoeducation about illness to the patients as well as the parents. They also create awareness about various government schemes and benefits, and also about skills training under the livelihood programs. So this is a picture of one of the residential camp activities, like where we actually take a public hall on rent, and then people are actually involved in various activities during this. So this ensures that persons with mental illness are networked with various stakeholders, including the NGO, the ASHA workers, the Taluk hospital, the district disability welfare officer, with the community, with the panchayat, the district court, as well as the composite regional rehabilitation centers. And parents meeting is also done once in a month, where we call them to the Taluk headquarters and then discuss with them about various things which they can actually be done. So over a period of time, we have been able to form a family federation for self-advocacy. And recently we have also started microcredit. So in this photo, you can actually see a person with bipolar disorder who has actually set up a shop using the small amount of about worth rupees 5,000 rupees, which was given to him on credit. There is another person with psychosis who has actually again started a shop. And you can see a lady with mild intellectual disability with psychosis who has been given a small goat, which she is growing up with the help of microcredit facility provided here. And we have been involving the ASHAs, that is the accredited social health activists in Jagalur CBR. So they were trained for 90 minutes by a psychiatrist in the local language. It was a didactic session, which actually where we told them about the symptoms, cause, outcome, and treatment of severe mental illness, and how to use symptoms in others' tool. It was an interactive session and queries were clarified, and ASHAs were encouraged to refer patients with mental illness to the nearby PHC or Taluk hospital for consultation. And we also shared the schedule of camps in various places. So following this, they were also provided on-the-job training where the patients were accompanied by ASHAs for evaluation. The patients were interviewed and treatment was initiated in the presence of ASHAs who were requested to supervise treatment and ensure follow-up. And we found, like, even during the home visits, like there are social workers from the project as well as from the NGO. So they accompany the ASHA workers when they go for a home visit. So the ASHAs actually observe them, how psychoeducation is actually done, how the medications are checked, and the project staff as well as us, we are available over the phone 24/7 for any guidance which is needed for the ASHA workers. So the benefits which we have offered to the patients as well as the communities: home visits by the psychiatrist when required, better supervision of treatment by the ASHA workers, and over a period of time, positive word of mouth publicity among the health staff as well as the community. So this is a photograph where they have actually interacted with the popular actress. And you also see the photograph of the district judge actually felicitating the ASHA workers. And we also had ASHA workers visiting our tertiary care hospital where we showed them ECT and a range of other facilities which are present in our center. So we also documented that once ASHAs were involved in the treatment of persons with mental illness, like there was significant change in the domains of benevolence, social restrictiveness, and community mental health ideology. And there was no change in the authoritarianism domain. And along with this, we have also shown that when we implemented a community-based rehabilitation project, then there was a significant dip by more than 90% of out-of-pocket expenditure in rural South India. And right now we are implementing an randomized control trial where we are involving ASHA workers in treatment of persons with mental illness. And the unique aspect here is ASHA workers will be incentivized for their efforts. And the trial is actually ongoing and we are analyzing the data. And because of impact of COVID, earlier we were seeing patients in person. Now we have shifted to the telepsychiatry mode, by which we have actually offered consultations through the ASHA workers, and we are also directly seeing patients over there. And during COVID, I think with the help of the local NGO partner, we have also been able to offer ration kits to the patients. So the current situation is like more than 400 patients with mental illness are availing treatment across Taluk. And out of this, more than 110 have been initiated on treatment for the first time. And nearly 300 patients have shifted from other centers to our program. The community has realized that mental illness is treatable and parents' participation has increased. So health staff are proactively helping us towards mental illness in terms of identification, indenting medications, referring patients, and as well as helping us in follow-up.
Today, I will be talking about the supported education and supported employment services that we have been providing in the Psychiatric Rehabilitation Services at NIMHANS. We start with supported education services. There are a number of psychosocial challenges in pursuing higher education, especially because of the early onset of psychiatric illness. Individuals or students who have mental illness have fears of failure, they have adverse effects of medications, they are discriminated in colleges, and because of this and the cyclical nature of the illness, they often lead to poor educational attainment, which in turn spirals into unemployment, low income, late age job opportunities, as well as poor social functioning. In this context, we decided to develop a supported education program, which we tested for feasibility and pilot at NIMHANS a few years ago. The program comprised of two main components. First was the supported education program for students and caregivers. And the second part was working with the educational institutions or the academic colleges. The sub-themes under each of these categories are given below. Some of the things that we worked with the individuals and the caregivers was trying to educate them about the illness, trying to work with their strengths, career counseling, group work with the client and his peers, trying to look at liaising and coordinating with the multidisciplinary team for them to come back, doing an academic college visit and follow-up services, apart from motivating the client to continue education. Work done with the academic institutions involved working with the management and the competitive authority about the academic settings, trying to bring about changes in the curriculum, working with lecturers and college counselors to try reducing the stigma and trying to look at inclusive education and working with the clients with mental illness in the school and the colleges, working with the peer groups and working with the parents in college settings. We also developed a number of IEC material, which was distributed in colleges and in camps that were conducted in various colleges. I shall dwell upon a case example to discuss on how the supported education program was actually implemented. We had a client, VSP, 18 years old, who had not completed POC and had paranoid schizophrenia. The barriers that he had was that he had poor support, especially from his father. His father had very high expectations from him. Poor reasonable accommodation provided by the college and the teachers. They felt that if he can't perform, he as well move out of the college. He also had a 1-year gap because of his illness symptoms. There were high expectations from the mother and also high expressed emotions. There was stigma from the college, his peers, as well as stigma from the relatives and neighborhood, because of which he faced discrimination and his education was interrupted. The supported education services that we provided were, we helped him with study skills, we helped him cope and manage his stress, especially while studying. And we taught him how to possibly schedule his day and also how to schedule his academics and studying. We did some supportive work with the parents to help them reduce their emotional burden and discuss with them how realistically they could support their client to achieve better. We helped him get his disability assessment done and certain welfare benefits. We also enhanced educational support from the brother who was never in the loop. We had sessions with the lecturers to see how they could provide the same lectures in a format which possibly can be understood by the client, and also some additional help from their side. We did facilitate free drug facilitation as he was from the poor socioeconomic background, and we psychoeducated the family apart from providing individual counseling to help him, motivate him to get back into education and provide study skills. The outcome of the entire process, which was over a period of 1 year using the case work methodology, the client passed second PUC with 95% and was preparing for NEET, which helped him in his further career. So the graphical representation over here shows that over a period of 1 year, with around 14 clients that we tried this pilot, we saw that any of the hindering factors that I spoke about or the barriers came down significantly. The helping factors, for example, the supportive factors from the family, from the teachers, from the college increased significantly. The self-esteem did improve over a period of 12 months, and the sense of mastery that they were doing something on their own improved over a period of 12 months. So the guidelines and recommendations that we came out with at the end of this program was who can do the program. We realized that it could be for 18 to 28 years, students with mental illness, especially with severe mental disorders, students who had previous difficulties in academic reintegration, who had completed a minimum of SSLC, and students who were interested in pursuing post-secondary education and mental health services, and who provided consent. The supported education program was beneficial to not just the students, but the parents and family members, the teachers, lecturers, and the NGOs whom we worked with to help them support in the college level area. The SCP services were provided by a psychiatric social worker, and it can be provided by a clinical psychologist, psychiatric nurse, or psychiatrist, or any other mental health professional who has minimum 2 years of clinical experience of working with severe mental disorders. We need to follow the following things, especially the ground rules of working with clients, maintaining confidentiality, non-judgmental attitude, and using the student's vernacular language while providing SCP. I'll now move on to supported employment, another program that we have been running at the Psychiatric Rehabilitation Services. The problem is huge. 87.3% of persons with mental illness are out of the labor force, and there are barriers in entering the job market due to stigma, lack of skills, and gap in work. Most of the NGOs that we have observed work in the area of vocational placement for other disabilities, not necessarily for persons with mental illness, and the needs of each disability are different. And hence, we believe that it was important to assess vocational potential, provide vocational counseling along with treatment as usual, enable the client to obtain and maintain a job in the competitive market, and involve all stakeholders in order to succeed in this program of supported employment. For this, we developed the vocational potential assessment tool and the vocational counseling module, which was scientifically validated by experts and also published in an esteemed journal. The process of supported employment that we followed was initially assess each client who was interested in getting a competitive job using the vocational potential assessment tool. We provided them counseling according to the vocational potential counseling module. We then networked and liaised with a number of corporates and companies in and around Bangalore. The number is almost equivalent to 40 of them, where we tried talking to them about how they can provide reasonable accommodation to place our clients. We then provided training and placement in some of the corporates, or we trained them at NIMHANS and then placed them, either one, train and place, or we placed them and then we trained them. Both the models were used. It was hybrid model. And we also provided other additional services like welfare benefits, UDID, or in case any other services were required for family rehabilitation, those were incorporated. The process of networking with the employees involved main 3 stages: initial contact. Most of them were from personal contacts or a new contact through open employment. Assessing the knowledge of the employer, trying to understand how much they knew about mental illness, then educating them and breaking their myths about mental illness. And finally, bridging the gap between the employer and the client through exploring vacancies, looking at the client's capacity and strengths, and working through reasonable accommodation before final placement. The employment status over a 2-year data is what I'm presenting is about 63, especially for only severe mental health disorders. For all clients put together in PRS, we were looking at a data of almost around 100 per year that we have been able to help through the vocational program. In severe mental disorders, around half of them, that's about 32 of them, were employed in competitive employment. Active attempts were made for 17 of them and referred for pre-vocational training, around 7 of them, and 7 of them dropped out from the study. Sustenance was a very important part of the entire program, and we saw that the median range of people who were employed was almost about 60 days. And at the end of 2 years, when we looked at the data, almost 9 of them were continuing to be employed in the current job that they were in. Some of them experienced adverse events that we have mentioned down, such as termination due to poor performance, termination due to IPR issues with colleagues. There was unplanned leaves that they had taken, so they were terminated, and relapse of symptoms. Non-adverse events leading to dropout from the employment, including poor motivation, too long distance from their home to travel to the employment place, non-preference of job profiles, in the sense they were not interested in the job profile that was provided to them, and also completion of contract period. The follow-up support that was provided from our side, the post-placement support, including at times traveling along with the client to teach them how to reach the place of work, liaising with the employer for reasonable accommodation, procuring welfare benefits, support with adjusting to the new workplace culture and colleagues. So we often went to the office and tried sitting with the client as a job coach in the initial period if the corporate themselves did not have a job coach. On-call support to the employer and participant at any point of time, and motivating the participant to sustain employment. Some of the reasonable accommodations that we asked from the employers was flexible working hours, slow and gradual exposure to work, having a single supervisor who possibly only knew about the about the status of the client without disclosing the illness to others, a weekly off, day shifts as much as possible, individual work assignments with specific instructions, less stress on deadlines, working from home options, minimal social interaction in the job profile, especially for those who had anxiety and had challenges in communicating, social skills deficits, and minimum workplace distraction or noise. Based on this, I would like to conclude that both the supported education and the employment program was found to be feasible. Good placement at job and education sustenance rates were observed with the casework approach that was provided. The institutes, the academic institutes, as well as the employers seemed extremely supportive of the entire program, especially after we had the initial rapport building with them. Retaining the job of the academics was the main problem or the main adverse event. And this was found to be challenging. So if we could look at how we could help clients work through the adverse events better, then the sustenance rates would be much better. These are some of the work that we have done. Thank you.